Oh my, have you heard of the O shot? This was brand new to me. And our guest, Kirstie Cunningham, on this episode, again, is very timely as we are just coming off of World Menopause Month. And while my own menopause experience hasn't been horrible because I have been able to use hormone replacement therapy, I have a load of empathy for those who have not been able to use HRT to manage sometimes horrible menopause symptoms. And keep in mind, we really focus on the physical symptoms, but there's also the mental impact that menopause has on women. Certainly, the medical community's opinion is all over the place on the topic of HRT when it comes to studies done with oral versus vaginal estrogen. And today's guest blew my mind with some data from a newer Danish study that may bring hope to women who have not been able to use hormones because of a cancer diagnosis. There is a risk-benefit analysis in regard to the severity of the menopause symptoms and the recurrence of the cancer. Following the data and consulting with your healthcare professional is the best course of action always, as the science is always changing. And speaking of science changing, wait till you hear about the O shot. Health, wellness, career, relationships, and everything in between. We're removing the taboo from what really matters in midlife. I'm your host, Michelle Folan, and this is Asking for a Friend. Welcome, listeners. Our guest today is a menopause and hormone specialist. Dr. Kirstie Cunningham is an obstetrician gynecologist who is also certified by the North American Menopause Society. Welcome, Dr. Cunningham.
Thank you. Thank you for having me here.
May I call you Kirstie?
Yes.
Great. I would love for you to tell the audience a little bit more about you, where you're from, and maybe where you went to school.
I was born and raised in Atlanta. That's my home. I finished my undergrad at Duke University, and from there I went to medical school at Wake Forest University, which used to be called the Bowman Gray School of Medicine, but they underwent some name changes. So us older people know it as the Bowman Gray School of Medicine. I finished my OBGYN residency in Chicago at Mercy Hospital. And then I came back home, and that's where I've been practicing ever since.
You have family and kids?
I'm married. We've been married now for 30 years.
Oh my goodness.
Past
Congratulations.
June. I have 2 adult children. My daughter is 23 and my son is 22. He just turned 22 last week.
Fantastic.
Yes.
We have done a couple shows on the different aspects of menopause, but we have not done a deep dive into hormones. I think you bring some personal perspective to this topic with some of your own experiences.
Oh, yes. I started my menopausal transition over 30 years ago. I was in college. I didn't know that's what it was at the time. I think other people around me, of course, they didn't know either because I was 21. That's not what you expect at 21. I do remember having hot flashes, and hot flashes are triggered by stress. I remember specifically when I would run to class, and there was this one semester when my schedule was just crammed. I had to take the shuttle from one campus to the other campus and then just barely get to this class just in time. I would slide into formation. It was an African dance class. I would slide into formation and then kind of then this wave of just heat would come over me. I would just start sweating. I thought it was normal because I had just run from the bus stop to the building. I didn't realize what that was. It would happen about 2 minutes after I stopped running, which was weird. That went on and on. I recall a time that my 2 younger brothers came up to visit me at Duke, and they were staying at my apartment. They kept telling me the apartment was cold. I just really did not understand how they could be saying it was cold. They kept asking me to turn the air conditioning down because they were freezing. And I'm like, what? No, I'm not turning it down. You know how kids are. So they called home to tell on me. to tell mom.
Oh my gosh.
And it's my mom from Georgia scolded me and told me to turn the air condition down
Oh my God.
in my apartment. That went on. Time progressed, still having hot flashes here and there, random places. My instructors would always go, "Are you okay?" And I was like, "Yeah, I'm okay. I'm just hot." I don't know why I'm hot, I'm just hot. Then, let's see, got married, went on birth control for just a short period. I stopped it really for vanity reasons because it was making me eat too much.
Well, I think that's pretty typical. We go on the birth control and we gain some weight.
The newer ones really don't make you gain so much weight. You may gain a couple of pounds, maybe up to 5 pounds over a 2 year period or so, but my appetite was just out of control. This was an older pill with an older type progesterone in it. Remember, this was probably 30 years ago.
Mm-hmm.
I just could not control my appetite, which was very unusual for me. And I knew it was this pill because that was the only thing I was taking. I stopped it. My period never came back, which they were irregular all my life anyway. I only had two a year. It never returned. I went to an OBGYN there. At this point, I'm in medical school. I went to an OBGYN doctor. She ran some tests. Of course, the pregnancy test was negative. I will never forget the day that she called me. I was on my way into surgery as a student. I was on my surgery rotation. She paged me. That's how long ago this was. We were still carrying pagers. She paged me. I stopped and picked up the wall phone.
Mm-hmm.
Again, another marker of time. Picked up the wall phone, called her back. She said, "Well, I have your lab results. I have some basically not so good news. It's going to be harder than we thought for you to get pregnant." Those were her words. She went on to tell me which levels and what that meant and everything. I was just really stunned and hung up the phone, went on into the OR. And in this case, that was really all I could think about. I couldn't even.
Oh,
Thankfully, I wasn't the surgeon that day. I was just a student holding a retractor.
that's a lot to unpack for a young woman.
It is. I just remember standing there holding the retractor. I know I had tears in my eyes because I couldn't even see what I was looking at, and I was just thinking about this conversation I just had on the phone. That's how I got that story. And from there, the next thing is she referred me to a reproductive endocrinologist. They did a workup and confirmed everything, told me what my options were, basically adoption or donor eggs. Me always being the one not to ever give up. I was like, well, let's try. They said, well, we can try these injections called Pergonal. It's supposed to stimulate your ovary to pop out an egg or something. I said, yeah, let's try it. It didn't work. It cost a lot of money, but it didn't work. They warned me ahead of time that it probably would not work. I want to say I did maybe 5 injections. They were very expensive. They were about $2,500 each.
That was a lot of money back then.
It was a lot of money, and insurance didn't cover it. We proceeded to investigate the donor eggs. That felt like now we're here. We sought out a reproductive endocrinologist here in Atlanta. We went through that whole thing, the workup and the psychology thing, just all of that. At the time, I was doing a year of training in Jackson, Mississippi. They were coordinating my treatment. We did the donor egg cycle. We did the IVF here in Atlanta, but then I had my blood work drawn in Mississippi. It came back that it failed.
Yeah.
So we did the donor eggs, it failed. I was so excited initially because I thought that I was pregnant. I remember going to church a couple of days after, and my brother saw me. He was just like, "Oh, you're glowing." I was like, "Really?"
Oh,
Like, really?
that's what every woman who wants to get pregnant wants to hear, that we've got that look about us
Yeah.
that's unmistakable.
Exactly, exactly. I was just sure that things were happening. When I went back to Mississippi and they drew the level, and it was some low number. Basically, it was negative. That failed. Interestingly, the donor that we use, they don't let you really see the donor. They pick it for you, which is very unsettling for me that this person is picking someone that they think looks like you. Interestingly, it was a shared donor. Another couple used the same donor and they were successful. So I'm like, okay, wow. They shared that with me. Good for them, but I don't know why it didn't happen for us. Time went on. That was probably back in 1993-ish
Right.
or somewhere in there.
Yeah.
Time went on. I prayed about it. I just let it go. I just felt like it was going to happen. From that point on, I just started thanking God every day for children, my four healthy children. 4 years later, it happened. It was a surprise when it did happen because at that point in time, I had been working out pretty much every day at a gym. At this point now, I'm in Chicago in my OBGYN training. I had been working out every day in the gym. I took a 2 week break. I don't remember why. When I came back, I couldn't keep up in class. I was just like, oh my gosh, how am I that much out of shape when I only took 2 weeks off? This is ridiculous. I was extremely tired. Then I went to a doctor then because I felt like I may have had an ulcer, which she thought so too, just from worrying and the stress probably of the residency or whatever, and had scheduled me for an upper endoscopy. Now we're approaching Thanksgiving. I tried to call and schedule this upper endoscopy, which is a large amount of radiation.
Oh, no.
I called them to schedule it. They didn't answer. So I left a message. I had to go to training. When I got home, they had left me a message, so they had missed me. We were playing phone tag with each other. Then it was Thanksgiving break. I went home. Then we went on our vacation for Thanksgiving. We were in St. Thomas. It's 90 something degrees or whatever in St. Thomas, and I was freezing cold, freezing cold. I remember thinking, this is so strange. Why am I so cold and nauseous? For the week preceding that Thanksgiving break, I just remember being very emotional about things. What's the toilet tissue commercial with the teddy bear?
Charmin?
Charmin, yes. I would like cry at a Charmin commercial. I'm like, okay.
Oh, now that's pitiful.
I'm like, what is going on? Because I am not a crier. I am not a crier. Really. Something is amiss here, and it's something more chemical. I said, I can't put my finger on it, but there's something going on that's not right. I said, well, maybe I should see a psychiatrist or something because this is not me. That was right before I went on break. So I went on break. Now we're in St. Thomas, and now I'm cold, and now I'm nauseous. I take that back. Sorry. I was not nauseous. I just didn't have an appetite.
Okay.
I only ate peanut butter crackers. That's all I had a taste for. Peanut butter crackers, and I was freezing cold. And my whole family was there, and they're all having fun, and I was just kind of like, ugh, exhausted. I felt like a truck had run me over. I just laid in the bed. If you ask my husband, he says I was extremely moody.
Moodier than usual.
Yes. We finished the vacation. That's when I started suspecting, well, maybe, just maybe, something has happened. When the vacation was over and I was back in Chicago, I was on call one night. I remember I still had some blood work that I was supposed to have done that the doctor had asked me to do. I said, I'm going to also do a pregnancy test since I'm doing that. 2 o'clock in the morning, since I was on call, I went away from our floor. I think we had the third or fourth floor. I went up to the seventh floor because I didn't want anyone to see
Mm-hmm.
over my shoulder what I was looking at. I checked my results and it said positive, the pregnancy test. I'm sitting there looking at this computer, blinking like, what? What? Really?
How exciting!
Yes, it was a surprise. So I called my husband at 2 in the morning. He was still living here in Atlanta. I was in Chicago and I called him and let him know. I was still very cautious, and so was he. What does this really mean? I called my doctor the next morning, and she decided we would get a quant. A quant, what that means is it actually measures the pregnancy hormone level, not just a yes or a positive or a negative. It measures the actual amount.
Right.
We did that, and it was an amount, and so then we got an ultrasound, and it turns out I was 7 weeks and a day already. 7 weeks and a day. That was my daughter. That was my first miracle.
That's awesome. Well, God listened.
Hmm.
Many of these stories where women get pregnant and they've struggled with the whole process, sometimes it's just when they stop hyper focusing on it and resign themselves to, okay, maybe this won't happen.
Hmm.
Then all of a sudden, for some reason, our body responds positively. Then
Hmm.
I don't get it. Did all of this with your trials and tribulations of getting pregnant, did some of that really spawn this interest in treating hormones in patients?
It did, because during that time, having hot flashes, I tried different types of therapy. We kept playing with it, and that's probably another thing that I feel like triggered an ovulation. I am not a good pill taker. I'm just not. I know myself. You know how people say, know thyself. I am not a good pill taker. I would skip the doses. I would just forget. Then the next day, oh my gosh, forgot, especially when I started having hot flashes again. I think just being so sporadic, and I'm not telling anyone to do this. I,
Don't live by her habits.
I don't know. That's just some hunch that I have there. I don't have any scientific backing of that. I know that I was just messing up. Anyway, God answers prayers. I do know that. So,
Yes, he does, and I do believe that. How often does that happen where you have early onset menopause like that? Is it very common?
it is not very common. The average age of menopause is 51. They've actually moved it up to about 52 and a half now. When women enter menopause before 40 is considered early menopause, and then earlier than that is considered premature. You can see at 21, I was way premature. So it's very unusual to enter menopause in your 20s.
Oh, frightening. We talk about perimenopause quite a bit
Hmm.
on the show. What a lot of women don't realize, me included, was all these symptoms that I had that I didn't know that's what it was. Some of the additional
Mm.
anxiety, body temperature changes, that sort of thing, because I couldn't figure out why, after I had my last daughter, this would have been in the 90s as well, I was having hot flashes.
Hmm.
I thought that was just post pregnancy stuff, but I was probably starting to get perimenopause.
That's very common, actually, post pregnancy. Now, you may have more hot flashes actually if you're breastfeeding. As long as you're breastfeeding, you're suppressing your estrogen production temporarily. It's like being in temporary menopause.
Oh, interesting. I did not know that.
Yeah.
When someone comes to see you
Hmm.
and they are starting to have some symptoms, what's the first step you usually take with those patients?
Step one is check hormone levels. Like you said, there's so many different symptoms. There's the classic ones, the hot flashes, the night sweats, there's libido. So if they have any of these symptoms, low libido, mood swings, brain fog, the anxiety, if they come to me with any of those symptoms, I talk with them about how these can be hormonally related. What I recommend is that we do a complete hormone panel, and with that, we also check vitamin levels. Many women complain of fatigue, especially in the mid afternoon. That just really wipes them out and makes them less productive than normal. We check the reproductive hormones, we check the thyroid hormones, because all of these can be a cause of fatigue, as well as the vitamin levels, vitamin B12, vitamin D. We also check the blood count. If you're anemic, of course, you're going to be tired. That's the first thing we do is check all your levels. After that, we bring them back for a consult in the office. So we sit down and we go over all of these results and we talk about how we can optimize everything and get her feeling better, get her feeling her best.
We know that not everybody can do hormone replacement therapy.
Hmm.
I know that the studies are mixed. Can you shed some light on that? Because I know we talk about estrogen replacement, and there were some studies that showed some adverse cardiovascular effects. And we also have your patients that may have had cancers that are hormone related. How do you vet that out, and who's a good candidate?
The first thing to know is that all of the hormones are not equal. Even though it may be a type of estrogen, it may not be the same as another estrogen. The study that really affected the way we use hormones these days is the Women's Health Initiative study that was done some 20 years ago almost. In that study, they used Premarin and PremPro. Those two products contain a conjugated equine estrogen. What that means is that product is synthetic, is derived from pregnant horse urine. It's an estrogen. They also used a medroxyprogesterone acetate. That was the type of progesterone that they used in it. What they found was in the women that used the product PremPro, which was the synthetic progesterone combined with the conjugated equine estrogen, those were the women that had a slightly increased risk of breast cancer. That's why they had to end that study a little bit sooner, that arm of the study, rather, a little bit sooner. They did not find that same increased risk in the women that only took the estrogen. There's a lot of confusion about that, especially when we put all hormones together. And if you just put one class on top of that to say hormones, yes, it's very confusing. But you have to remember that what we use in bioidentical hormone therapy is not the same as what they used in that study. What we use in bioidentical hormone therapy is an estradiol. It's plant-based. It's structured to be very similar to what you would normally produce. The same for the progesterone. It's a plant-based progesterone. It's structured like your normal progesterone. Now, as far as cardiovascular, there is a newer study, I think it was released by the American Heart Association, and other studies now are showing that you really should start hormone therapy within 10 years of menopause in order to decrease your cardiovascular risk. In addition, if you start hormone therapy within 10 years, you will decrease your risk of dementia. But we know that you only get that protection, get the greatest protection, I'll say it that way, if you start within 10 years.
That makes sense. I would think that estrogen would be cardioprotective.
Yes, they both are, but in an indirect way. The estrogen will help you to reverse some of those lipids. First of all, let's go back to when we're younger. As women, we normally have a higher HDL, which gives us protection. That's the good cholesterol. And then the LDL, which is the bad cholesterol. HDL starts dropping as you age. That's just a natural phenomenon. If your LDL starts increasing, which also happens as with age, you can see that that's a risk factor for cardiovascular disease. In addition, when you start losing your estrogen, you start developing insulin resistance. That can take you more towards diabetes, prediabetes, diabetes, which is another cardiovascular risk. When you bring the estrogen on board, it helps to reverse all of that. It helps to reverse that lipid profile back to the way it was, and it helps you to reverse your insulin resistance.
I have a couple friends that are breast cancer warriors,
Hmm.
as I call them. You and I are speaking in October. I think this is a good time to probably bring this up because it's Breast Cancer Awareness Month. They're all on hormone suppression therapy right now, and they will be probably for the next 10 years or so.
Hmm.
For those patients, they won't be an ideal candidate for HRT or hormone replacement therapy. Are there things that you can do in your practice to help these women
Hmm.
with the low sex drive and painful intercourse and that sort of thing that I know plagues many of them?
Hmm. About the hormone therapy, for women in our practice and for your associates, patients that have a history of breast cancer or current breast cancer, what we tell them is that although the estradiol that we use does not cause breast cancer, we do withhold it. We don't enter that territory. But they are still candidates for testosterone replacement therapy. The testosterone replacement therapy can actually help resolve their symptoms. There are hot flashes, their joint pain, their night sweats, their mood swings, and the low energy. That's what we do currently with our breast cancer patients. We give them testosterone hormone therapy. That helps them greatly. If they just don't want to do hormones at all, then there's still options for that as well. options for hot flashes. We do things, there's the patches, there's an antidepressant that will actually treat hot flashes. Those are both well studied. For libido issues, we are now offering the O shot. The O shot, using the patient's own regenerative properties. That way it's natural. We draw a tube of blood from the patient, we spin it down, we get their plasma, which contains their platelets. We put it in a couple of little specific spots that will then help them with orgasm. It helps vaginal lubrication. And for those women that have urine leakage, which is very common in us women that have had children, it actually helps with urine leakage too. It helps to stop that stress incontinence.
I went on your website and saw the O shot.
Mm-hmm.
My jaw was on the floor because I had never heard of that.
Really?
I think it sounds amazing that if someone can't take hormones or doesn't want to take hormones, boy, that checks off a lot of boxes for a patient.
Yes, it does. Yes, it does. The nice thing is it's just one shot. The success rate is not 100%, but it's 85%, 85, 90%, which is pretty good.
That's awesome.
I think it's a great option for women.
How long does it last?
About a year. It's not permanent.
Do you also treat men in your practice?
I do. I do. We have several male patients because they want to feel good too. There's this thing called andropause, which is like the male menopause. The hormone levels in the men start dropping around age 25. They experience problems too. They have a lack of libido, they have fatigue, they have the brain fog, they have some of the same symptoms as women. They come in, they want to get their libido back, they want to get their energy back so they can be as productive as they were or be able to lift the weights that they want to lift in the gym. We treat them too.
I think, to be fair, all things being equal, this is not just a female issue. I know a lot of times you have couples where there's a lack of intimacy. Sometimes it can be the male partner that is maybe not feeling as amorous as he was in the past because of the lower testosterone. And you know what else? We, as we get a little older, may not feel as good about our bodies. It can make us feel a little more self-conscious. I think men may have some of those same body issues that women do. I guess, too, how often is it that the wife or the female partner is the one dragging the husband in to get his hormones checked?
Yes, that happens quite a bit, actually. I would say in half of the males we've treated, the wife has sent them in. And he'll come in. The first thing out of his mouth is, I don't know why I'm here.
Oh.
My wife sent me.
Yes, you know why you're there. There was a discussion at home, but I get it. They're not used to having those conversations, right?
Exactly. I think it's a whole ego thing for the men. It's very touchy, I think, for them. I think it's more touchy for them than it is for women sometimes. Men are supposed to be so virile, and then here they are, and they maybe feel a little less virile or broken, even. To your point about the women, yes, as we age, your body starts changing and you don't like the way you look anymore in the mirror, and then you're feeling tired all the time. You just start feeling old. It starts messing with your head even. When a sexual encounter occurs, then you're doing this self-monitoring. And when you're self-monitoring, it's hard to have a sexual response. You have to break that cycle somewhere. You have to either break it by overcoming these thoughts, just spontaneously overcoming the thoughts, or you have to break it by doing something with your hormones or doing something with your weight, something positive, and making the changes that you like to see in yourself.
I think there's a component of self-care there that we need to put ourselves first. But I also think we need to give ourselves some grace.
For sure.
We're expected to gain some weight in midlife. A lot of times that gets deposited around our middles.
Midsection, yes.
I thought it was cool. In your practice, you also offer fat reduction treatments for people's midsections. And I think that's kind of nice. It's one-stop shopping.
Yes, I do. I do. Exactly. That's what we're trying to do for our menopausal ladies out there. If you want to get that belly toned down a little bit, we're here for you for that. We do that in about 8 sessions. We've had some really good results with that. Really good results. That's not to say that if you gain some weight that you have to get rid of it. No, you don't have to. But if you just don't like it, if you want to get back to the way things were or closer to the way things were, then that's what that's for.
I always say on the show that do what makes you feel good.
Exactly.
No judgments. We have to be supportive of each other, whether you decide to do a little fat reduction in your belly or you choose to embrace it. You know what? That's a personal choice. You're very fit. You take good care of yourself. What does your own self-care routine look like?
hmm I work out in my house. Yes, I'm very accustomed to working out and I like to challenge myself. I like doing things like the obstacle course races. I'd done a couple of those the fall of 2019 and then January of 2020, just before the pandemic hit or COVID hit. I was actually training for a half marathon when everything just went haywire with the pandemic. That has been put on hold. Now, I got COVID in June or July of that same year. It really affected my legs. I lost a lot of muscle mass during that time. It took me, I would say, about 9 months to feel normal again. But even then, I struggled with my knees. When I was really sick, I could not even stoop down to pick up a piece of paper because I would just crumple to the floor. I could not get back up.
Wow.
That's how weak my legs were. When just months before that, I could squat with 200 pounds on my back. This is the difference that COVID made.
That's devastating.
During my recovery period, I really couldn't get up the stairs. I mean, I really had to grab the rail and use my arm strength to pull myself up the stairs. I'm still working my way back from that. I've been in physical therapy to help strengthen my legs, the exercises and whatnot. Now I'm at a point where I have much less knee pain and I'm able to run. I just restarted a regimen. I did a regimen, a training regimen on my treadmill where they take you from wherever you are and they get you to where you're running 30 minutes straight. I have to say, hats off to this trainer. Tommy Revs is his name. It's one of the trainers on this Nordic track. I said, okay, I don't know how that's going to happen with me, but okay. As he said, trust the process. I said, okay, I'll trust the process. It was a really great program. You start out and you run for maybe a minute or two, and then you walk for a minute. He just builds and builds and builds and builds until the last day of the last week, you're running for 30 minutes straight. I was so excited. I told my husband, I was like, oh my gosh, I did it. It was almost the equivalent of a 5K. I liked his program so much. I'm doing another one of his programs. I'm running for 30, 35 minutes straight now with no knee pain.
That's a great inspiration for your patients, too.
Yeah, I'll do that. I'll do the running, then I'll do the strength training because as we age, we have to remember to do our strength training to build that muscle. You're naturally going to lose muscle. You want to slow down that muscle loss with your strength training. I'll run for a bit and then I'll do some weights.
We've talked about that on the show is more protein in our diets,
hmm
doing the strength training.
hmm
I often say too, I'm on Instagram quite a bit. I see these women and they're throwing around a 25-pound dumbbell. That can be a little intimidating for someone just starting out.
hmm
How do you tell your patients, how do you get them started?
You don't even have to have weights to start. You can just start using your own body weight. There are so many different trainers out there. If you want to go to the gym, that's great. Many patients already have a gym membership, but they don't utilize it to their maximum. Use your gym membership. Seek out the trainers in your gym. They can help you and put you on a program, or at least have a couple of sessions with you where they show you what to do, these things to do to accomplish your goal. Also, there's lots of trainers online. There's gobs and gobs of stuff that's out there, and a lot of it is free, even. Even on Instagram, there's lots of trainers. I save their videos all the time and go back and refer to them. There's lots of stuff. You can just use your body weight to work out. Just start there. If you've never worked out before, start with your body weight exercises. Then you can gradually build up. Get a 2 pound weight, then a 5 pound, 10 pound, until you're up there. No, I would never tell anyone if you're just starting out, go get a 20, 25 pound dumbbell. No. No, you may hurt yourself.
I'm working my way there, but I'm not there yet either. This is great advice. I love some of your insights into hormones.
Mm-hmm.
There's so much confusion out there. And just to have someone who, this is such a core part of your practice and your certification, I just want people to know that just do your homework.
Mm-hmm.
Go find a doctor who's going to listen.
Keep looking.
Absolutely. Put yourself first. If you're not feeling great, get it checked out.
Right. If you go to your doctor, some doctors may not be as well versed in the hormone therapy because it's not training really that we receive in medical school. We don't receive anything about menopause. It's training you have to seek out afterwards. If you go to your doctor and they run some hormones and they say, oh, everything's normal, and you don't feel normal, you keep looking. And I would say really seek out a physician that specializes in hormone therapy because they will have a different interpretation of those lab results.
Great advice. You have a presence on Instagram and you also have a website. Where can people find you?
My Instagram handle is Dr. Kirstie Cunningham, and that's Kirstie Cunningham, Dr. Kirstie Cunningham. My website it's Metro Health and wellness.com.
Perfect.
The other website about the O-Shot is www.oshotsexy.com. www.
That's so funny.
.oshotsexy.com.
Got it. I will put that in the show notes.
Thank you.
Dr. Kirstie Cunningham, thank you so much for being on the show today. I really appreciate it. I look forward to catching up with you again.
All right. Thanks, Michelle, for having me.
Thank you.
It was a pleasure.
Follow Asking for a Friend on social media outlets and provide a review and share this show wherever you get your podcasts. Reviews and sharing help us grow.